Let's begin a series of brief audio clips over the chapter on therapy or the treatment of psychological disorders. We're going to first cover psychiatric treatment, and then we'll cover psychological treatment. If you remember psychiatry, these are physicians who follow the medical model, viewing symptoms of mental illness as biologically caused, either related to brain abnormalities, illnesses, or too much or too little neurotransmitter being secreted, and therefore, if it's a biological problem, then a biological treatment can be developed. Psychiatry has been very effective with major mental illnesses over the years. In America, back in the 1950s, 1955, we peaked at around 550,000 psychiatric inpatients in all of the 50 states, which is a huge number considering that now we have under 100,000 psychiatric inpatients in all the 50 states. Many psychiatric facilities have been closed due to primarily the success of first-line antipsychotic drugs. First-line meaning these are powerful and routinely show great effectiveness in a broad majority of inpatients. To gain inpatient status at a psychiatric facility, nowadays one has to be identified legally as a danger to themselves or a danger to others. So suicidal thinking, homicidal thinking, and down to just the inability to provide basic self-care for oneself. We noticed that the very, very sharp decline in psychiatric inpatients began around 1955 when the very first antipsychotic drug called Thorazine was introduced, and almost overnight, people who had been long-term years, 10 years, 20 years, inpatients, unable to leave the hospital, all of a sudden began to clear of their hallucinations and their delusions. It was a great boon. Unfortunately, I don't think the medical community and the psychological community was prepared because they had nowhere to go. Their parents had died. Their siblings didn't want anything to do with them. They burned their bridges due to their suffering of psychiatric illness. And sorry for the telephone going off. And so very many of them were unfortunately released to the streets. The gates were opened and they were sent out with the clothes on their back. So many of them became homeless. Some of them turned to crime to meet their basic needs. And so if you remember, there was a chart that as psychiatric inpatients decreased, prison populations began to increase, and we still see that today, even though now we're much, much better at planning aftercare for every person who's released. They have to have a place to go, a support system built in, and if they don't have a support system, they're provided with a support system with local mental health clinics where they're not inpatients, but they're able to go and get basic care, even medication follow-up. Different classes of psychiatric drugs. I know this is a lot of information. By no means do I expect you to memorize or know the names of the drugs, but it's important to know the classes. So we have anti-anxiety drugs, also called benzodiazepines. These are primarily drugs that slow down the brain. So people with crippling anxiety problems will take a drug that will sedate, generally, but also decrease the symptoms of anxiety. Problems with taking anti-anxiety or benzodiazepines is that they're habit-forming. Taken in high doses, they work pretty well, and a person can become slightly dependent upon them. Taken in high doses, they produce kind of the woozy, intoxicating effect, and so many people who start out with low doses will gradually increase their dosage, feeling better and better and better, and becoming very dependent on these medications. Some of the risks of anti-anxiety medication, because they don't treat the source of the anxiety, they just treat the symptoms. As I take the drug to deal and cope with my overwhelming feelings, the reality that's creating those feelings in the first place, whether it's my own thinking or the situations around me, it doesn't go away. And very often problems compound over time. And so you have anxiety rebound effects. Stop taking the anti-anxiety drug and you're even more anxious than you were before you took the anti-anxiety drug. That's called rebound. Antidepressants, well-known antidepressants. Prozac and Zoloft are probably the two most well-known. I like Paxil. Particularly, it's within the same class. It's an SSRI, selective serotonin reuptake inhibitor. Seems to work very, very well for young people and has the added benefit of decreasing anxiety. Paxil taken in low doses does a good job with anxiety problems coupled with depression. For most of these drugs, you'll see a 40 to 60% improvement. Usually after 3 months. These are drugs that don't work like anti-anxieties. The anti-anxiety, you take the drug and 30 to 45 minutes later you feel the effects. Antidepressants, many people report never really feeling the effects. It's just over time there's a slow buildup of the substance within the person's system, and they notice that their symptoms are decreasing. It's the way they're designed to work. A slow buildup with a continuous impact in the brain to allow the person to have more energy, greater focus, less sad thinking, and the other symptoms of depression improve as well. It'll be important for the exam for you to know that 25 to 30% of the time in tests of the effectiveness of antidepressants, the group that's given, the control group that's given the placebo, the dummy pill, the sugar pill, and told that it's an antidepressant, actually report symptom decrease or symptom improvement 25 to 30% of the time, which means perhaps when I take Prozac, partly the drug is helping, but also partly my belief in the drug is helping. We have mood stabilizers for bipolar disorder, lithium being the front line, the most powerful. Don't really have an anti-manic drug, but they are able to kind of move the person down out of mania and help them stabilize within the mid-range. Works reasonably well if the person takes it as prescribed and stays on it. Antidepressants are designed to be a 3 to 6 month treatment, and the person's able to get off because the brain has taken over. For mood stabilizers and antipsychotics, once you start one, you have to work very closely with your doctor if you want to change that medication or get off that medication totally. Getting off the medication can be very dangerous without monitoring by doctors. And then the antipsychotics, here's Thorazine. Haldol is another first-line antipsychotic. More recently, Zyprexa, Risperdal are used. Risperdal is even used in very, very young populations as a help for sleep and a help for decrease in aggressive behavior. Sometimes aggressive behavior, especially in youngsters, is viewed as a psychotic reaction, as an outside of reality reaction to minor or moderate stressors. Then we have ECT, electroconvulsive therapy. This is shock treatment, which used to be widely used within psychiatric facilities. You'd have these mobile bags that physicians could carry, plug into a wall outlet, and shock a person right where they were without any sedation, which resulted in a massive seizure. People would bite through their tongues and break their limbs due to the thrashing around. And what they saw in long-term use was that these patients were suffering severe memory impairment, severe memory loss. It's a major lawsuit in many states, and the use of shock treatment was outlawed in public institutions, although it's still available in private institutions. And it's no longer useful for antipsychotic treatment, but for people who are severely depressed and nothing else has worked, no medication has touched it, a person can sign up for ECT And after 3 or 4 weeks of treatment, 3 times a week, I've heard or I've read that there's pretty profound improvement over time, and their depressive symptoms begin to drop away. All right, that closes psychiatric treatment. I'll stop here and pick up starting to talk about psychological treatment.